Sure. Welcome, everyone. Thank you so much for being here. To our guests, panelists, and to all people outside of MCNY and to all those inside MCNY. We're going to hand it over to our peer leaders very quickly, but before we do that, we wanted to tell you a little bit about the Black Maternity Health Initiative, BMHI. So this project, BMHI, was student-driven, alumni-driven from the beginning. It began with a roundtable last December, late in the year. We thought not many people would come. We decided to just have a community conversation. We didn't have outside speakers, which we often do. It was a wonderful conversation. We focused it on Black maternity health inequities because it was a topic we had heard about from students before. And the conversation was just very passionate and it was a call to action. So we were able to get a small grant to support more work on this topic. And this is the beginning of the project, these two roundtables, and the peer leaders will be shaping different initiatives within the initiative. So we're very happy you're here. And Tina Callender is going to tell us a little about another aspect of the project.
Hi, once again, Tina Callender, the Evening Reference Librarian at MCNY. And I want to thank all our guests and viewers for coming and contributing to this conversation this evening. As many of us are aware, advocacy regarding Black maternal health and the high mortality rate amongst Black women and their infants has become a much needed conversation, as current statistics have shown us. And since starting this project in the early spring semester, and in conjunction with our ongoing weekly meetings with peer leaders, we are developing a collection of books, which you will see on our main webpage if you go into mcny.edu, and also relevant articles that have to do with maternal health care, and will be available for staff and students to use for further information and ongoing discussions that we have. I am a researcher just by nature, not as part of my profession. And so the deep diving that I've been doing pretty much on a weekly basis, daily basis, constantly finding quotes that reference from various places that just reference maternal care and the lack of it in different communities. I was just recently reading in a memoir written by a Mexican Latina. She's talking about her experience of assimilation into the United States, having lived in the United States and getting her naturalization, and speaking to it from a historical point and speaking to the fact that culturally they have midwives, but they're not approved of in the United States to be midwives and having midwives within their culture. And this is Mexican American. So it runs the gamut in all kinds of ways.
Thank you, Tina. I'm Kate. I'm the director of the library, and Tina gave me a perfect segue. I just wanted to take a moment to talk about why is this happening in a library? And that the answer to that might not seem obvious to everyone, but it was obvious to us. Baked into the very notion of a library is that access and space and ideas and information is a human right, and that we should all work collectively, that we should pool resources and share them. That's what a library is. In our library and in this project, we draw on a tradition called Participatory Action Research, PAR, which recognizes that information is more than just like a right. Information is power. According to the Highlander Research and Education Center, PAR puts that power in the hands of people seeking to overcome problems in their daily lives. PAR is a collective process of investigation, empowerment, and action. People most affected by the problems investigate and analyze issues and ultimately act together to bring about meaningful long-term solutions. And that's an idea that's at the heart of all of MCNY's pedagogy, and it's certainly at the heart of our library, and it's at the heart of our project, this project. And so I think I turn it over now to Warren. Thank you.
A warm and pleasant good evening to everyone. Thank you all for taking the time from your busy schedule to be a part of this evening roundtable discussion centered around Black midwives, doulas on the Black maternal health crisis. One might ask, why did we choose to focus our discussion of the Black maternal health crisis on Black midwifery and doula care? One, to raise awareness around the services that doulas and midwives can provide for expectant mothers and birthing people. Two, to get a better insight around the framework of doulas and midwives and what they do. Three, to foster the conversation about how the assistance of doulas and midwives reduces and/or impact the mortality rates. Because of various legislations that are currently introduced in New York City to expand doula care. And last but not least, to gain knowledge from you, our guest speakers, just to learn about the overall work that you guys are doing and how we, the peer leaders, can get involved. So again, I said, welcome. Okay, as it relates to time, there will be a 4-minute max time as it relates to answering each questions. At this time, I will introduce our moderator page. And let me at this time officially welcome our guest speakers for this evening proceeding. Shane Jones, Carmen Mojica, and Dr. Kesiha Goode. We will begin with an individual question for each. With this individual question, you all will respond individually. We will also invite you to respond to 2 general questions. And this question goes like that. What is your why for dedicating yourself to midwife or doula work? And if you can share any thoughts on the overturning of the Roe v. Wade impact on Black maternal health? Thank you.
So now we're going to turn to the individual questions. The first question is for Shane Jones.
So my name is Michelle again, and I will introduce Shane Jones. Shane Jones is a full spectrum fertility. She's a birth postpartum doula, CEO of NYC-based Melanated Mermaid Doula Services. And our question for Ms. Jones is, what is a full spectrum doula? What are the benefits of a doula care, and how does doula care address fertility and reproductive technologies such as in virtual fertilization? This question is for Ms. Jones.
Good evening, everyone. I'm a full spectrum doula. Full spectrum doula is someone who deals with birth and pregnancy in all the different stages and various stages. Pregnancy does not necessarily mean it's going to end in a live birth. Some people go into pregnancy knowing that if there are complications, they want to have their pregnancy as long as they can. Some people know that they are pregnant, but they do not want to move forward with their pregnancy. And so there are doulas for different specializations. And so with the second question was addressing fertility. And can you just repeat the second question for me, please?
The second question is, how does doula care address fertility and productive technologies such as in virtual fertilization?
Okay, so with the doula care, Doula care is a support person. So this is a person helping you with understanding all different levels of what you're going through, not necessarily only with your body, but also walking you through with research, helping you, providing you with different resources so you can make educated decisions for yourself. So with virtual fertilization or any other type of work outside of regular pregnancy, a person would be able to go with you into the office with prenatal care, then walk you through the different options of what steps did you want to take in terms of pregnancy, because some people know that they don't necessarily want to go that route, or they want to go the more holistic route. So a doula would work with you and walk you through that, let you know your options, educate you, help you with finding resources, helping you with finding and locating a doctor that might be best for you, or just sitting with you after and listening to you after you've gone through the experience of trying to work towards getting pregnant, and helping you with understanding that, sometimes like it doesn't always end up in pregnancy, but you have that person to counsel you through that. And was there a third question?
Yes, what are the benefits of doula?
Benefits of doula care, besides having a person who their goal is completely for you, is nothing, and you're not needing a doula with the intention for them to walk you through what they would want. It's someone who's literally supporting you in what you would want in terms of pregnancy, or what you would want in birth, or you would want in sex. So that a doula is someone who is going to support your decisions and make you feel informed and make you feel validated on making your decisions. And also with the curiosity, some people go into the doctors and in any type of medical situations and they're nervous and they're anxious. And so having somebody who can help you breathe it through and helping you to teach you how to write your questions down so everything does get addressed, that you're not going in there flustered and feeling like your questions are not necessarily getting answered.
Thank you.
Good afternoon, everyone. My name is Naomi. I am one of the peer leaders, a recent graduate of MCNY. My question today is for Carmen Mojica. She is an Afro-Dominican midwife doula. She's a writer and reproductive health activist. And the question that we had for you today is, can you please explain the difference between midwives and doula, and what made you desire to do both? Thank you.
Sure, no doubt. Good evening, everyone. So, the difference between a midwife and doula is within the scope of their work. Doulas provide non-medical advice around the physical, emotional, and psychological process of birth. And what I mean by non-medical is that they're not prescribing or diagnosing in any way, shape, or form, but are more giving resources and advice and techniques to be able to manage the pain and the process of childbirth. And also in the postpartum. They're specifically trained in this, though. There are a lot of doulas that have come into it just by way of who they are in their communities and being called by people in their life to just show up. But most doulas that you'll come across today have had some type of formal training, whether it was 3 days or a longer training period. They're usually hired by the birthing family, and so the loyalty of the doula is to the birthing family. They often are able to point the client in the direction of different providers and resources. Doulas usually have an ear to the ground because they are exposed to different practices and different birthing settings. They're able to give a better assessment and report to the parents if they want to know their opinion or what to expect at a certain birthing location. Midwives are medical professionals. They're experts in pregnancy, childbirth, and the postpartum. They are arguably the oldest profession on the planet. They are responsible for all of the medical aspects of a person's journey through their birthing process. So they're the ones that they're doing basically the same tasks and medical tasks as obstetricians and gynecologists, but they are specifically focusing on childbirth and pregnancy. The scope of nurse midwives and midwives around the world and in this country does encompass whole-person care and gynecological services, with the ability to collaborate or refer to a different specialist outside of their scope. I chose to do both. One, because I wasn't, I felt some trepidation becoming a midwife. I didn't know if I wanted to be in that space. So I decided to go and become a doula. Also because I knew that I had this skill and this ability to bring comfort and calmness to people already before becoming a doula. And then decided to become a midwife, because at the first birth that I went to as a doula, I'm like, I can be more supportive if I am able to offer more of my expertise and skill and things that I know, instead of stepping in at the end of the pregnancy and having to undo and undo all of the things that their provider may have done to not help them have the birth that they desire. And then the other piece is that I became a midwife as a form of direct action. I've been politically active since high school, and so becoming a midwife was an extension of that, especially and specifically for people of Afro descendant people, and also in allyship and conspiring with indigenous people to protect our rights, to family and sovereignty over our bodies.
Thank you.
Hi, everyone. This is Cabrina Stevens again, and I will be introducing Dr. Kesiha Goode. So a little background about Ms. Goode. We have her as an assistant professor of sociological, at Old Westbury SUNY, and author of Birthing in the Black Body, Midwives and Maternal Outcomes in the United States, forthcoming from Columbia U Press. Yes. So the question we have for Dr. Goode is, how do the personal, professional, and intellectual / academic sociological come together for you around the topic of Black midwifery?
Good evening. Thank you, Cabrina. That is a really big question, so I'll try my best to answer it. So I am not a midwife. I am very deeply invested in midwifery, but specifically Black midwifery in the United States. So how I came to be invested is I grew up in the DC area, and I was a teacher after college, and I knew that I wanted to pursue doctoral studies at some point. So I got a master's in women's studies in DC, and then eventually moved to New York to get a doctorate in sociology at the CUNY Graduate Center. And I initially wanted to kind of extend the education work. I initially wanted to study how Black maternal literacy practices impacted the kind of experience and joy of reading amongst Black boys, because I was teaching primarily English and language arts. And like much literature and language around Blackness, it was a lot of it coming from, at least my perspective at the time, a very kind of deficit model around Blackness, specifically as it relates to education. And I really wanted to switch course because I did not want to contribute to that literature. So I started thinking about Black motherhood more generally, kind of how people enter into the world, what are the conditions by which Black people are entering into the world. And this was about 2010 that I started to consider those things. And I was really lucky in that a woman, a sociologist, Barbara Katz-Rothman, was at the Graduate Center, who's written a lot about kind of contrasting the medical model and the midwifery model, and was really active in midwifery in the US in the 60s and 70s, and still quite active, but really sort of at the rise of the home birth movement, was quite active as an academic. And long story short, she ended up becoming my dissertation advisor, and I knew that I wanted to study the experiences of contemporary Black midwives in their professional organizations and education institutions. And I knew that it was completely ahistorical. Midwifery is very white contemporarily in the United States. The vast majority of midwives are white. And as Carmen alluded to, that is very, very, very ahistorical. That midwifery has such a long history in American history, but specifically Black history and Indigenous history. So I wanted to look at basically what was going on there. And at the time, there was an organization in Portland, Oregon called the International Center for Traditional Childbearing. And this is a lot of alphabet soup, so sorry. They are now the National Association to Advance Black Birth. You should look them up if you're not familiar with them. They do really great work. But the woman who was the founder of ICTC at the time, International Center for Traditional Childbearing, was really like one of the big holders and conveners of Black midwifery at the time. So she would hold summits and conferences, her name is Shafia Monroe, to really bring birth workers together, midwives and doulas. And she was really wonderful to me, connected me with a number of Black midwives, not just for the purpose of kind of doing the research, but she really did ask me to stay committed and stay in community with Black midwives. And that is what I have done. So I ultimately did a dissertation in 2014, Birthing Blackness in the Body, about experiences of Black midwives. And the short answer about the why is issues of structural racism and barriers inside of the midwifery profession. But that is not unlike most professions, certainly most health professions. The OBGYN workforce, it looks very similar in terms of what's happened historically, in terms of race. And so my personal investment is that I'm a Black woman living in the United States, and I'm deeply invested in Black life and abundance and joy. And my interest in it extends beyond the maternal mortality. Like, I think that is one thing for us to talk about, is that this crisis is very expansive. There's mortality, there's morbidity, there are issues around consent. There are a lot of things here. But ultimately, we want more than people to not die. We want people to thrive and be joyous. This is about community and family. So yes, I'm an academic, but I spend the vast majority of my time in community with midwives like Carmen, because it's important to me. And I'm on the board of the National Association of Certified Professional Midwives. I'm not a midwife, but I'm on the board there as a public member. So I hope that answers the very broad question. Thank you. Thank you very much. We are now going to be moving into 3 general questions. And this question was prepared by our peer group leader. To you, our panelists, these questions are complex questions with more than one question. Feel free to address whichever part of the question applies to you.
I hope that's my cue. So my name is Yvette Marshall. I am one of the peer leaders, and I'm thanking everyone on the panel that you're here visiting. It's been such a delight listening to you and learning. One of my, so I am a former alumni of MCNY in the MPA program, and I'm presently also doing another master's in education for elementary. One of my questions is, what kind of training is involved in becoming a doula or a midwife? And that's for anyone on the panel. The second question is, what should a birthing person look like for the qualifications of a doula? That's my second question. And my third question, sorry, my eye a little bit foggy. Given the low rate of Black and Latina midwives and doulas, what difference do you think it would make for a Black or Latina woman to get involved to becoming a doula or a midwife?
I could answer the training one. So there are three different certifications of midwives. There's a certified professional midwife. Certified professional midwife is the only certification that requires out-of-hospital training to complete the education. Certified professional midwives can go through the PEP process, which is self-study and self-documentation of apprenticeship experiences for them to be able to sit the NARM, which is the North American Registry of Midwives exam. Or they can go through a MEEC accredited school. MEEC is just the Midwifery Education Accreditation Council for the certification of certified professional midwives. And then we also would sit the exam for the NARM. Then you have certified nurse midwives. Certified nurse midwives are registered nurses who have gone on to get their master's degree in midwifery. Their experience is predominantly in the hospital and is hospital based. Most CNMs are found in the hospital setting, although there are some that practice outside of the hospital in birth centers and also in home birth. Certified midwives are not RNs, but they do have a bachelor's degree in another field outside of nursing, and then go on to get the master's degree in midwifery after taking the prerequisite courses for that. They also work in the hospital setting and home birth and also the birth center setting.
And I can answer the doula question in terms of being with doulas. There are certified doulas where you can go through a training that Carmen had mentioned. There are 3 day trainings, there are full day trainings, and then there are like 6-week trainings. And then there are people who are not certified who just walk in their purpose and they do their research on their own. But you can be certified or non-certified. I know there were 3 questions. Can you repeat the questions, please? There's the second and third question.
I think that the third question was giving the low rate of between Black and Latina midwives, what difference do you think will make for Black and or Latina women to get involved in becoming a doula themselves?
I'll speak to one part of it and then I'll pass it back to you, Shane. In terms of like a basic outcomes question, in terms of physiologic outcomes, again, I know there's a lot of investment in, as there should be, around mortality, but that's not the only physiologic outcome that we are looking for, but physiologic and also experiential in terms of how people feel about their birth and their pregnancy is just as important, if not more. So I'll put a link to the chat for the Birthplace Lab in Canada, who's done a lot of really interesting and important work around experiences of mistreatment and notices around respect and consent. All those things are just as important. But we know that there's this thing called concordant care, that when I'm receiving care from somebody that looks like me, or we share some sort of cultural background, whether it's race or ethnicity or gender or sexuality or religion or place or whatever, that outcomes improve. physiologically and experientially. And that is across the gamut in terms of profession. There's some good data out there about concordant care, specifically around GYNs and patients, some really good, interesting national studies around that. We don't have that as much for midwifery. Midwifery needs some more data work, like big picture data work, but we know still it matters in all professions. And so there's a bit of a number of casualties happening here. If we think about the landscape of perinatal health in this country, that GYNs and midwives are positioned on this larger landscape, and collective, like Carmen gave all of the types of midwives, collectively this problem around low numbers of Black people, Latinx people, just BIPOC people in general is low in these professions. And that has a major impact on the crisis that we are seeing, that not having a predominantly white workforce that does not match representatively in the United States. It's not that shocking why we have the crisis that we do. So there's a major workforce issue here, and concordant care is so important. And also, the United States government has to take responsibility also for this crisis. It cannot be the responsibility of midwives and doulas and GYNs to save the crisis. That's never going to happen. That these are big structural issues, that there are social determinants of health that impact the crisis. Access to medical care is like 20% of our overall health. There are other big things, like very basic things that we know around food and climate change and feeling safe in neighborhood, all of those big picture social determinants of health, including issues around structural racism and justice, that those things, that's 80% of our overall health. So it's all of these things combined that really, really matter. It is Black midwives and Black doulas I'm so invested in. I'll give my life to it. It is still a part of the overall picture.
Thank you for sharing your thoughts. I just had to interject. Thank you.
Thank you.
There was another question about given the rate of the Black and Latina midwives and doulas, if it would make a difference. I think it would make a difference, but I also have to speak to something that I have observed throughout my life, which is that all my skin folk are not my kinfolk. While we can increase the amount of people of color that are in the health profession, it's not enough to just increase that without them having a critical lens of the situation and also being aware of their privilege as well as their own internalized depression. Unfortunately, when folks, especially in public hospitals, are experiencing violence, yes, there'll be a white doctor involved, but more often than not, it'll be someone, a nurse or a medical aide or a doctor or a specialist that is from their culture or looks like them that is exacting this violence. And so while that can be helpful, I shy away from saying like, yeah, that's definitely what we need if folks are not being given this anti-oppression, anti-racist lens to be able to enter the professions so that they can be safe and equitable providers for everyone.
Thank you again for answering all the questions. At least on my part.
Janine, I saw your hand.
Okay, so my question concerns, I guess it's somewhat general. Who pays for a doula, or when do you use a doula? I know maybe Shane had mentioned earlier, you have a loyalty to the family, and there are different types of doulas, a full spectrum. Whereas a midwife would be more of a professional individual. So Dr. Goode, you had mentioned social determinants of health and how that also affects the whole process of what we're talking about. The question for me is, being that we know a doula would be helpful to, say, a young woman in, like, say, a teenage mom, right? Or someone who has no clue, first-time mom. She's getting ready to give birth, and she may be not comfortable about the process. You mentioned also the whole hospitalization process and how it may be quite intimidating. I would look at a doula as a first respondent, as me coming into this community health education process. So you're like a first person to educate the mom what breastfeeding is, healthy, feeding the child, and getting them to a place where, okay, I'm a young mom, but I want to produce a healthy child getting into the world. So I guess my whole idea is, why isn't it not seen as, I'm formulating the questions because it's overwhelming, because I do have an investment in the topic. But what I'm getting at is, being that you have an important role to play in the Black family, why isn't it that institutions do not recognize the work? Is it that we still need more research? Being that we know that doulas and midwives in our Black community over time, from slavery, we know that they have been the first birthers and nurses through the process. If that would help to mitigate Black maternal, lower the rate of Black moms going through this process, wouldn't that be a target? Wouldn't you be a help in that area to help that process? I know I said a lot. I think I'm trying to bridge quite a few gaps right now. I'm trying to speak on the purpose of the doula to help mothers who are low income. Let's put it like that. Who pays for it? Is that a private situation? Is my insurance going to cover it? Or is someone else's insurance going to cover it? How do we make that distinction, that to have a professional, as you're saying, you're invested based on your purpose, yes, and also understanding that there's a value for what you do, knowing that sometimes the environment of a Black woman giving birth in this country can be difficult. How would a young mom who is interested in having someone like a doula, knowing that a doula is a motivational person, you're giving them strength through the process, because you mentioned full spectrum from start to finish and postpartum. So I'm trying to understand, wouldn't your role be important to the upper echelons of healthcare in understanding that this can also help to mitigate the instances of mothers going through that difficult process? I don't know if it made sense, if anybody can kind of follow what I'm saying. That's just my thought, I guess, if anyone understands where I'm coming from.
I think Dr. Cummings just put something in the chat. Dr. Cummings, do you want to speak to it?
I could just very quickly, in answer to Janine's question, for a small, I'm Dr. Allegra Cummings. I'm an OBGYN at Weill Cornell Medical Center. And one of my colleagues, Dr. Audra McDougall, who's the clinic director, works with a program called Embrace. It is trying to do exactly what Janine just outlined, which basically is attaching doulas to patients that are in the NYP Weill Cornell system. And it's something that is in the works that they're actively working on. And obviously this is one medical center out of, New York City, out of all the cities in the United States, but it's actually doing exactly what Janine has proposed, and 100% agree that that could be one small way that we can try and get people in our system aligned with doula care, which we know is going to help them to have advocacy, have a voice, give education, and the program has grants so the patients don't give anything out of pocket. So we're working on it in a small way in my institution.
Thank you.
Hi, everyone. My name is Wilhelmina Barriet. I'm one of the peer leaders. I'm an undergraduate. I'm in my second semester. So I have 3 questions for the midwives and the doula. So you can answer anyone that is referred to you. So my first question is going to be, how do you as a birthing person find out about doula care and midwifery options? And my second question is, what is being done and can be done to spread the knowledge about these options? And the last question is, what about payment or insurance? And what if a person cannot pay for the service they get in, like for insurance? What if a person cannot pay for the service they get in, like our delivery or going through pregnancy?
Usually people find out about these services through a variety of different channels, but namely lately has been through exposure in the news, or like news stories, through social media, and folks that are also connected to like Healthy Start programs, or community, or they are being helped by community health workers, usually especially in New York City and in the Bronx. People are already connected, but I think people are still learning, especially if, depending on your education level, you're still learning about midwives and doulas. Also, when I think about the Bronx is not hegemonous, it's very multicultural and multi-ethnic and immigrant populations in the Bronx. So I mentioned that to say that in a lot of people's home countries, midwives are either seen as respected healers in their community or something that is indicative of poverty. And so there's an education around that still needs to happen around, like, the demonization of midwifery and how home birth is not a sign of poverty, because some people equate giving birth outside of the hospital as your only option, and giving birth in a hospital as a sign of being modern and a sign of that you're not poor. So there's also that piece, right, when you're talking about who is the most susceptible. And that's not just people that are immigrants, but also African Americans and generationally who also lived through the demonization and the near eradication of midwives in this country. I think that hospitals specifically, which is where most people access their their services for prenatal care and childbirth, could do a better job of informing their clients if they have a midwifery practice in their hospital, to try to refer all birthing people who are low, I hate saying low risk, but are generally healthy and don't have pre-existing health complications, and refer them to midwives. I think that could be a really good mechanism to put the word out. I think also the Department of Health has tried to put out information about birth justice and doulas and midwives, and I think that if they took the recommendations of community a little more seriously, they could possibly spread the word a little further. And also, like, programs like this, I think, remind me of the fact that birth is not the responsibility of doulas and midwives, but birth is the responsibility of the community, because that is the vehicle through which a new community member comes into your world. And so with that said, like, as more people who aren't giving birth or are part of, like, family structures, brother, father, cousin, family friend, play cousin, whatever you consider your role in the community to be, to be invested in whomever is around you who's going to be giving birth or is pregnant, sharing resources that they may not know. It doesn't have to come down only to healthcare professionals, especially if you have at any point in your life complained about your neighborhood, or like, there goes the neighborhood is effed up and it's not getting better. Well, if this is the knowledge you're holding, then if that's your sentiment, it's also your responsibility to, if the little bit of knowledge that you have, to pass it on, right? A little bit goes a long way. But through New York City, actually recently, there was a citywide program that made doulas available throughout the 5 boroughs, for women who lived in specific area codes, and it was like free of charge and all this other stuff. So there is more money coming down the pipeline from the top, from the White House, on through different communities. So slowly but surely the money, and it's all connected to money, the money is coming to be able to put and make more of these initiatives grow.
Hi there. I wanted to jump in quickly and address a couple of things that were said. My name is Desi Robinson. I'm a professor at community health education at Metropolitan College of New York, and I'm so pleased to be here and to see so many folks here, and to see Dr. Goode and Carmen and Janine and our folks who are our panelists. Really, really excellent to see all of you. I wanted to address 3 really quick points. I think the first one Carmen made about sort of the perception of doulas and doula work, and having it really be attached to midwifery and shaman and witchcraft. And like, if you keep going back further, you'll see that, you know, witches and women with knowledge and with power have progressively been suppressed and oppressed throughout our society. And that's really where a lot of this work comes from, through the healing arts. And so I find that a lot of that work has been, like many other things, has been co-opted, gentrified, culturally appropriated. And so you'll see oftentimes now that many affluent women and white women are using doulas, and that is, you know, something that is considered kind of like progressive and hippy dippy, and often something that people who can afford to do those services and have someone specifically care for them as a mother or birthing person, that they can afford, because it isn't largely covered by insurance. And so I do think that, like, same as urban farming, which is generally something that Black and Brown people have had very deep connection to, their connection to the earth, that gets kind of, you know, washed away because of Black and Brown people's connection to slavery and working in the fields, and people wanted to not be oppressed in those ways, and they wanted to be able to buy those things in supermarkets, and people wanted to be able to have their babies in hospitals. And so the demonization of so many of the things and the co-opting of so many of the things that come from Black and Brown and Indigenous people have been reworked and remixed to be these sort of new cultural, like, touchstones of things that become part of luxury. So health and birthing and all of the things that had generally been connected to either women's work or poor people's work has been remixed and co-opted for communities that can afford them. And so I think it's really important to look at the origins of what we had and what we did and what we created, and how that has been appropriated and suppressed and oppressed through white supremacist practices. The other thing I wanted to make an important point on, I think Janine had a question about like who needs a doula. And I think the answer is everyone who is birthing can benefit from a doula. And I think that one of the reasons that I specifically became a doula is when I saw the very abysmal outcomes of not just poor women and poor teenagers and people who didn't get prenatal care, but poor birthing outcomes are being experienced by Black women with PhDs who are married, who have insurance, who have jobs, who have all of the things that we claim are the things that elevate you in your life and bring you protection within your life. And so there are even statistics that are showing that a white woman with a high school diploma can have a better birth outcome than a Black woman with a PhD. And that tells us very specifically that it has to do with race, and it doesn't have to do with access or the ability to have prenatal care. If we're living in a country where people like Beyonce or Serena Williams have difficult and poor birth outcomes, postpartum outcomes, and these are two of the most wealthy, and those two women are no shrinking violets. So these are not women who don't speak up for themselves. These are not women who have a difficult time accessing. Beyonce shut down a whole wing in a hospital to have a baby, and they're still having adverse outcomes. Excuse my nephew who's tracking behind me. That has to do with race. Actually, it has to do with racism, not just race. The third thing I wanted to say is I did put some information in the chat about the citywide doula initiative, and I believe Carmen was mentioning these particular area codes. They were called tree neighborhoods, where there had been the highest level of adverse outcomes, birth outcomes. And so the citywide doula initiative is covering, I would say, those tree neighborhoods, and it's worth it to check it out and see if it will be expansive to all neighborhoods, but it is available to people who are on Medicaid free of charge. And also the double duty is to make sure that doulas get paid and to make sure that we could clearly define who doulas are, what their work is about, and how they are literally contributing to having better outcomes. And so I am on the advisory board of the citywide doula initiative, and I felt that it was really important to share that information in this conversation. So thank you again, and I look forward to hearing the rest of what we're going to chat about this afternoon.
Thank you, Professor Robinson. This is Greta again. And when we met a couple of weeks ago, we spoke of that phenomena called weathering. And we are hoping that in getting the voices of these women who are out there, who are part of the higher echelon, I'm talking about women of color, that if we can also get them to raise their voices, that it would give this whole thing validity and credibility, that this is not just about socioeconomics, it is about structural racism. So I think weathering is something that will be addressed in the next roundtable discussion, and how we can get these voices raised so that people become aware, because we know that everything that you do in this country, every drive, we must have people who are public, who are personalities, people who on Twitter have 1 million followers. These are the people who we can get to speak about weathering and about the structural racism that goes into birthing in this country. Thank you so much, Professor Robinson.
I would like to call on Dr. Goode just to share some remarks based on what Professor Rob just mentioned. Can you please share some remarks? We'll appreciate that. Thank you.
Yeah, sure. The one piece I want to raise here, just from like a big picture kind of sociological perspective around power, that there's a long story here, and I encourage people to read it about, as Carmen has mentioned, about the kind of attempted eradication of midwives, and specifically Black and Indigenous midwives. And Dr. Robinson has also addressed this issue too. There's a lot there. And these are intersecting around power. This is very much so about whiteness and white supremacy and racism and patriarchy all colliding to work towards the attempted eradication of midwifery specifically. And when we talk about the home birth movement, that has been very whitewashed, and we've talked about it as kind of a revival of midwifery, but that is a very white narrative that Black midwifery has always, even though it got minimized, but Black people in the South were birthing with midwives well into the 1950s and 1960s. So some of this is just the way that this story is told. But going back to the landscape of kind of maternal health in this country, again, we have doulas and midwives and GYNs and lactation consultants and nurse practitioners. There's a bunch of professions that kind of land in this space, and not just pregnancy and birth and postpartum, but just all aspects of sexual and reproductive healthcare. Hormone therapy, fertility treatments, like all of these things are a part of it. And power is a big piece of this. Like, we cannot underestimate the significance of the Professional Association for OBGYNs, that ACOG historically, even in New York City, which Carmen can speak to, has had a major impact on specifically certified nurse midwives being able to practice, who, I should know this because I'm on the board, I think we're up to 34 states or something like that. But even within that, scope of practice is largely influenced by ACOG and also ACNM, the certified nurse midwifery and certified professional midwifery, or certified midwifery, profession, that the closer you are to medicalization, the greater your scope of practice, the closer you are to home and community practice primarily, like certified professional midwives, like Carmen would like to do in New York, is largely really influenced a lot by ACOG. This is a huge, huge power struggle over power and knowledge. And we know that in other places of the world, I also kind of cringe a little bit with Carmen around the risk thing, but we'll go with it, around low risk people being able to have midwifery care as just sort of the standard way, because we absolutely need GYNs, absolutely. I am not that person that is like no, we need them, but they also have a place. They are not generalists, they are surgeons. And that also really impacts the way that they primarily view birth. That said, in terms of, and a lot of that is even people with the best of intentions. So this is not about individual people. This is about systems, that when we are in systems that are unjust and oppressive long enough, our lenses get a little distorted. So this is not about individual people, but all of those big power things, like ACOG specifically, influence also the cultural narrative around this too. And so, yes, we do need the Serena Williams and the Beyonce. We need all of those people. And I think they have done really important things, and Tatiana Ali, around raising awareness. I would just sort of push that I think we are beyond the raising awareness stage at this point. There is more than enough information. It is a little ironic me saying as a researcher, but we've got enough of that. Also around specific disparities research, just that, like, Google is your friend, that we have more than enough to detail this. This is now, we are at a place of action, and people have been working on this issue for a very long time. There are a whole group of people, reproductive justice folks, advocates, professionals, so on, that know what the solutions are. We have the solutions that are available. This is not a no-brainer. The White House doesn't need anybody to do more research. This is about how we provide and care for people. It is about social determinants of health. It is about diversifying the workforce, with that important caveat that Carmen made about we need justice-oriented Black and Brown people in these spaces. I would just say we don't need a whole lot more in terms of documentaries and so on. We need people in power to get it together and to follow what we know already work. We have the information. We have more than enough that we need at this point.
Thank you so much, Dr. Dr. Barbara, Melissa, I see you have your hand up. And do you want to
Thank you.
just
I
wanted
actually I wanted, and thank you, Dr. Good, for saying what you said. One of the reasons why I wanted us to go back to Miss Sharon Thomas's question about the profession being practiced without a license, because what you just said and why I wanted us to address that and why it's very important to address that is because the minute power structures take over, they begin to license, they begin to put in requirements that literally push out certain communities from actually accessing the things that they've always done. And so one of the reasons why I wanted us to actually begin to talk about that and address that question, because if we're going to talk about power dynamics and we're going to talk about how things have been whitewashed or how things have been literally reframed to criminalize midwifery and the whole doula structure, it comes from the fact that those power structures knew exactly who they wanted to be a part of the structure, right? And my training, I'm trained as a medical physician, and so you understand the difference of the dynamics and how the closer you get to medical structures, it's more legitimate, or they try to make it more legitimate. And so I think that answering that question and talking about the fact that you have people that now have to be licensed, they have to do all of these other things. There's nothing necessarily wrong with that, but how many doulas that we know back in the days from down south were licensed to do doula work? Right? How many of them actually had those certifications and degrees to do the work that they did? And they did it very successfully, right? So now we're in a world that literally tries to legitimize a specific profession by degrees, but they isolate people from getting those degrees, right? Or they target specific people into getting those degrees so that the community that once practiced, that once did these structures and knew how important it was to have those professions within community-based settings, they're no longer there. And so we're seeing the crisis that we see, right? Because the structures, the doulas, the midwives that were once in our communities are no longer there. Right. And so I just wanted us to actually be very aware of that. Like when we talk about these power dynamics and we're talking about like power structures in play, we have to understand that there was a level of pushing certain people out of those professions, right? As we got closer to the medical field, as we got closer to the medical professions. So I just wanted to mention that, and thank you so much. This has been such a great discussion tonight, and thank you so much for all of the plethora of information that is going. But I think that if we go back to I think Miss Marshall and her question and what she addressed in terms of how do we actually bring this to the forefront so that our young people, people in BIPOC communities can literally gravitate to these professions once again. Like, how do we do the work of literally legitimizing that these are professions that are very much needed in our community, that are very important, and that people can actually go towards these professions and make, an adequate living off of these professions and do the work that they so love to do within communities. So how do we actually promote these professions as something that our young people can actually get with and go into and know that it's something that they're doing to actually put dents in the crisis that we're seeing, but also that they're going to be doing collective work within the community that's very important to the health outcomes of generations to come.
Thank you very much. Carmen, Mojica, I believe you had your hand up. Can you, do you want to chime in at this time?
Sure. So how do I feel about the profession that I am in being licensed? Well, I feel two ways. I think that I inherently reject having to be licensed and be certified in something that is part of our ancestral birthright. And with that said, I feel that it is magical thinking to believe that we can do away with certification and licensure right now as society looks. And it's magical thinking, because to be able to access knowledge on that level, there comes a certain requirement of commitment and loyalty to community, commitment to human rights, and to being an ethical human being, and to also be able to download information, right? When we're talking about our ancestral healers, they were very much connected to spirit, uncolonized spirit. And so we're still a couple generations out from being able to safely address the needs of our community without these structures that we have, namely because we're not yet, there's not enough of us yet invested in creating the alternative structure. So like I've never, maybe as in my 20s, I was like burn it all down to the ground. But with age, I have recognized that we can't say to hell with certification when there's tens of millions of people who are still in the wind, who need those services. Like there needs to be some type of either scaffolding to not have certification. There needs to be like family, like community and family, like repairing happening. Like there's a lot of us that don't trust our community members and people that claim to have healing knowledge, because unfortunately not everybody is ethical or can be trusted, right? And so we need to talk about the ways in which trust has been shattered in community, not just through colonization, but also through the internalization of that. And then when we're talking about birth specifically, most people who give birth identify as women, and so they have been violated in their body. And so to be able to be a midwife and be that intimate with someone requires a high level of trust and also understanding of how to walk people through such intense body experience with the likelihood that they have experienced trauma. So although I don't like certification, the other piece is that I'm Black. Just existing can get me arrested. Like I could breathe wrong and that's it. That's what it says on the document. Then they write you up. She breathed wrong, or she looked at me wrong. Like, so I personally am not in favor of leaving people exposed to another layer of criminalization without licensure and certification until we're able to address systemic racism, criminalization, and incarceration as well, right? So it's kind of like almost like a catch-22, like damned if you do, damned if you don't. While I think that it's necessary for the community to be responsible and in charge of their healers, we're just not there yet. Like we talk about community, and I feel like it's like this, it's almost fictional sometimes. Like how many of us know who lives across the hall or downstairs or upstairs? Like if we're not even there yet, removing certification and licensure does keep people safe. Are people harmed in the hospital system and X, Y, and Z? Yes. Is there a way to be able to keep track of who is your healthcare provider and how to file a grievance? Are these systems perfect? No. But we have accountability in this, and then people already get hurt. Less accountability, we're not there yet.
Thank you very much. Shane Jones, any thoughts on that subject matter? Thank you.
Yes. In terms of what doulas being certified, I feel like it's, like Carmen said, it's a catch-22, depending on where you go and what you're catering your knowledge to. Because you can go to a school where you don't necessarily learn to actually be with a person, and then you're thrown into fire when it comes to like going to a hospital system. So I do think that it's important to get certified in terms of there's so many different levels to understanding how to support a person. And most of the people that I know that are doulas, they're coming from a place of being in the community and understanding trauma. And so if you're understanding trauma and trying to help address someone's trauma, you need to be knowledgeable. You need to take classes, or at least put yourself in certain settings where you're speaking to people and you're getting an understanding. Because even we see people who work in social services who just go straight into work and then don't necessarily help, or they're giving knowledge and it's harmful, or they are the connecting person and you're the direct person, and then you can scare someone from going to asking for help. So, but there are community doulas that are, I know that there was a question in reference to payment in the past. There are community doulas who, like myself, who would work on sliding scales because they work in the community and they know what the community needs. And so they're not going to be working in a certain community asking for things that they know that people in the community can't provide. Like people, they understand that, are aware of that. And I do know that it was mentioned in terms of how we can get people to know and understand more. And word of mouth has worked for years and centuries. And just like this great panel, you have this opportunity to, I see all people of different like ethnicities and different backgrounds and different age groups. So we as people, we need to make sure that we're going after this and teaching people what we learn and explaining what birth and what health looks like. Because public health is not just like one blanket statement. It's not just one thing. We need to know and understand in terms of preparation and preparing ourselves. So just like conversations with sex, they do happen at home. Conversations with support and therapy, sometimes they definitely happen at home. Conversations with in terms of how to seek support. Because I know we keep on talking about birth, but as a doula, I don't necessarily only deal with birth. I don't necessarily, and when I say full spectrum, I'm dealing with the person and understanding that maybe a person who has a 9 to 5 is not necessarily the same person who has the same needs as a person who doesn't have a job, who doesn't have finances. So seeking a community, making sure that you're seeking a doula that caters to you. Because I have clients that are married and they are older and they know exactly what they want from birth. And then I have clients who are teenagers and this was their first sexual experience and they have no idea what to expect from their bodies. And I can get the same level of questions from both and the same level of being scared from both. But they sought me because having consultations and understanding, like, okay, this is a person that I feel like can be present for me. So there are doulas that work in the community along with like a city doula initiative, but there are doulas who you can look for online and they look pro bono, or they work on barter systems, or there are doulas who just want to make sure that they're present because they understand that this person doesn't have the person who's present for them. So there's different levels of what you can look for when you're looking for a doula. And it's not the same thing as terms of when you're going to a hospital, you're working with the team that's present. If you're hiring a doula, this is the person that you're hiring for yourself. Even if you're paying this person out, you have to mesh well with this person. This is something that even with partners, when I sit down, I don't just necessarily talk to the birthing person, I talk to their partner and ask how I can be present for them as well. So knowing what you're looking for is one thing, there's research for that, but also making sure that you're interviewing this person and seeing who can be present, because we get into, your mind is not necessarily the same when you're in panic, when you're doing things out of fear, and there also, you can have the opportunity to seek a doula at any point in time in your pregnancy. At any point, if you're a person who has a womb, if you're a person looking to have you need any type of support, they're a support person. So they're not just birth related, the people who are looking to become pregnant, the people who have had miscarriages, there are doulas for miscarriages. There are doulas for abortions, there are doulas for death. There are doulas for all types of situations to deal with birth. So when they say full spectrum, that's what I mean.
Thank you very much.
And we just have a few minutes, and I saw the question about Roe, and I think that that's important for us to address. And I think there's so many things here, again, kind of going back to the responsibility of our leaders, that Roe was a really important legal precedent, but it was always the responsibility of those in power to codify that into law, and they have royally failed us. And so we are seeing the consequences of that. And Roe is, yes, it is about abortion, but the larger precedent is around right to privacy. So this is absolutely directly related to what we are talking about, as we all know. That issues of contraception are important here. All aspects of reproductive technology are important here. Hormone therapy, gay marriage, I mean, you name it, all of this is now up for grabs, so to speak, for lack of a better word here. And so issues around bodily autonomy, agency, self-determination are being attacked. I won't say like never before. I mean, we could just read history, but we have a major responsibility here as citizens to resist this, but it is another catastrophic failure of those of people in power. And issues of community and community activism. I always appreciate hearing Carmen talk about how she got into midwifery, because midwifery is a profession and it is also firmly rooted. In order for it to be effective, it has to be firmly rooted in justice. And so reproductive justice is essential. It is the foundation, and reproductive justice is the right to have children, to not have children, to parent them in safe and healthy environments. And at all ways, our country is failing us. And so I just want to really push that this is not just about abortion. It is about our basic this is a human rights issue. And the forced birth is a human rights violation, but somehow the United States gets to go along as it is. So we have a lot of work to do as citizens, but the people in power have royally failed us.
Thank you very much for that. Thank you.
Hi, so can everyone hear me okay? I'm still healing from a cold.
Yes.
Yes.
Hi, my name is Sharon Thomas. I'm one of the peer leaders for the Black Maternal Health Initiative. And I'm also a graduate student at MCNY's business school, and also training to become a full service doula. My question is to Carmen, Kesiha, and Shane. To all of you, I would like to give thanks to you all for holding space with us, for your extensive knowledge. Thank you to everyone for all that you've already done and for driving this forward, continuing to drive this forward. It's a two-part question. The first part of this question is, where do we go from here? And the second part to that is, what can we do? You know, if you can point by point, let us know, what can we do to help you with the work you are doing now?
I think I sometimes struggle with these kind of questions because of what I said. Not actually the responsibility of midwives and doulas to come up with these solutions. That it's actually your responsibility as folks who are part of the world to figure out what happens next, because I feel midwives and doulas have exhausted what happens next. We've started clinics, we've started birth centers, we've started easy access centers, we've started schools, we've gone to the Department of Health and told them and like stated our case. Like, if anything, midwives and doulas can sit down now, basically. And I think that's my question to y'all, is as people who are going to be taken care of by the next generation, as people who are mothers, sisters, cousins, aunts, youth educators, bosses, people who are eventually going to age and going to need the people that are going to be born in the next 20 years. What are you going to do about this? What are we going to do? Because my solutions might not resonate with you. My solutions is not going to resonate with everybody. And so I'm actually resisting this idea that I have to be the one to come up with this, because this crisis is a threat to humanity. So we all need to like step back and be like, all right, well, what is my role here? I think that this professionalization and like education system and schooling has made it as though that there have to be messiahs and like saviors and people who are holding this knowledge, when really it's all of us. And so that's my response. I don't know what we're gonna do. What are we gonna do?
Thank you. Thank you for your response, Carmen.
Guys, I just wanted to jump in quickly because I see that Dr. Goode has to leave, and I wanted to express my thank you before she takes off. So I'm just going to give a quick thank you, and then we can just finish up. So in closing, I would like to thank each and every one of you for being a part of this evening roundtable discussion. I myself learned so much, and I'm pretty sure that others can attest to learning so much. But what I would like to say at this time, I would like for us to keep in touch if there is any ways that we can keep in touch, and just for us to continue the connection and the conversation as it relates to this subject matter. So again, I said thank you guys so much for being here, and we appreciate all the knowledge and information that was shared here today. Thank you so much again.
Thank you so much for having us. I put my email in the chat. Anyone is feel free to email me at any time, especially the wonderful librarians around research and all kinds of things that might be helpful. Thank you so much, everybody.
Thank you.
Really
Thank you, Dr.
nice.
It
was really wonderful.
Thank you.
You enjoyed
so
that?
much, everyone.
Take care.
Thank you. Thank you.
Thank you.
Yes, thank you so much. This was great, and I would love to go to the next roundtable and just share and listen. This is great.
We'll
and
look for
I
you.
appreciate this community for giving us the opportunity to speak and to hear and get to see other people in this work and the different levels of this work and how it's touching people. So thank you for this space.
Thank you.
Thank you so much, everyone, and Shane and Carmen. We will be in touch. We will be sending out a feedback form to everyone. And we got so many more ideas for the second roundtable. I'm sure the peer leaders have also. So we're looking forward to that.
Good night, all.
All right.
Congratulations again, Lorna, on your graduation.
There's another graduate in here as well. I forgot.
Congratulations.